Good afternoon. Welcome to Panel 2, Pandemic Treaties and Travel Restrictions, the present and future of this wonderful conference organized by CCPL at HKU on COVID-19 borders and the law. My name is Eric Ip. I'm an associate professor of law and the deputy director of the Center for Medical Ethics and Law at the University of Hong Kong. This panel consists of 3 presentations, each lasting 20 minutes. The presentations will be followed by a 20-minute questions and answers session. Let's get started. It's my great pleasure to introduce our first speaker, Professor Susan Breau, Dean of Law at the University of Victoria in Canada, to assess for us the effectiveness of the International Health Regulations 2005 in the response to COVID-19 in the coming 20 minutes. Professor Breau, please.
Thank you very much, Eric. I first want to say what an honor it is to be invited to speak to this distinguished audience and panel at the University of Hong Kong. I'm quite nervous today because it's such an important topic, but also something that's very difficult to distill down into 20 minutes because it's one of those expressions you have in the United States, don't get me started. I could go on for days about how bad the response was from the international community. So if you give me a minute, I'll just share my screen to start the PowerPoint presentation. So in 2019, I was asked when the COVID pandemic first started by Victor Ramraj at our Center for Asia Pacific Initiatives at the University of Victoria, whether I would contribute a chapter assessing the response of the international community. So I wasn't asked to look at individual states, but the international community as represented by the international health regulations to the pandemic. My co-author and I looked at the response as of early 2020. So it's quite some time ago. And I have to say the world has moved on quite a bit since we assessed our response. But I have to say, if you read our chapter and the criticism of the implementation of the international health regulations, the review committee that was established by the World Health Organization and its recommendations, well, their recommendations are very similar to ours. It was my thesis, our thesis, that the key to responding to a pandemic is compliance with international law and strengthening the regulatory mechanisms of international law. Now, I have to say that when the pandemic first arrived, I was involved in a group called the Disaster Law Network that I was involved with called IdealNet. And we had been looking for quite some time. And in fact, I'd co-edited a book on international disaster law. And of course, one of the first things one has to do in dealing with an event that impacts the whole globe is look at issues such as preparation, response, and international cooperation. Well, I think no one here is going to be surprised by my assessment that the COVID-19 pandemic is an example of lack of cooperation, lack of preparedness, lack of response. And in fact, I think it's going to go down in history as one of the worst responses to an international catastrophe. So the first thing that we looked at were the provisions of the international health regulations. And as I said, I could go on all day, and I'm not going to with respect to the various provisions. But what had interested me in looking at the media coverage was how long it took for there to be a declaration of a pandemic. There's often been criticism that China delayed in notifying the World Health Organization. Well, in our examination of that, we could say that China delayed by days. The World Health Organization delayed by a full month in declaring an event that constituted a public health emergency of international concern. The truth was that there is no definition in the international health regulations of what a pandemic is to be. And when the International World Health Organization met to decide whether indeed there was a crisis, they didn't agree. There were meetings and there was a disagreement as to whether or not this in fact constituted a provision of international concern. Well, imagine me sitting in my living room, literally wanting to throw something at a television, screaming, as I'm sure most of the population of the globe was saying the same thing. This is a pandemic. This is an international emergency. For God's sakes, declare it to be a pandemic. Well, as I said, it wasn't until the 30th of January when an emergency, a public health emergency of international concern. And don't ask me to define what that means, because frankly, I don't think the World Health Organization knows what it means. The other thing, there's two sides to this response. In fact, in doing my research, I spent a lot of time in looking at articles in Lancet and public health articles, because there wasn't a lot in the beginning by international lawyers about what was going on. But clearly the response by public health officials were, well, you know, the problem isn't really with the international health regulations. Yes, there was a delay, but there was a complete lack of coordination and unity by states in responding to the crisis. The development of the vaccine is an example of the selfish behavior of states. We here in the United Kingdom, where I am now living, and by the way, I'm no longer dean at the University of Victoria, I'm a happily soon to be retired academic. Well, we're on our fourth dose, as are many developed countries. And when you think that a great portion of the world is still struggling to provide people with even a first dose. Those of us who have had COVID know that probably, and I'm over 65, that our lives were saved by that vaccine. That if we hadn't been vaccinated, we would have been seriously and probably critically ill. So the fact that millions of people have died of this disease for complete lack of coordination in distributing the vaccine, I think it's going to go down. Well, I'm a bit dramatic, but it's almost like an international crime. We had the means to prevent many, 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 many deaths. Now, on the other side, and I haven't put it in my slide, but what astonished me in the response by the globe, and we never really got a strategy as to how to deal with this, was this vaccine hesitancy. Now, I know a lot of this conference is concerned with human rights issues, and I totally understand that one can't force a vaccine into somebody's arm. But the fact that there was no coordinated strategy about how to combat vaccine hesitancy across the globe. And, you know, I'm astonished by that vaccine hesitancy, and I probably will be to the day I die, because when you think of how many people's lives could have been saved, it's just a shame. In our chapter, when you look at the complete lack of coordination and unity, we also said that even developed countries, the United States, for example, that had disbanded its pandemic response unit in the White House, there was a complete lack of preparation and a complete lack of willingness, again, amongst political leaders to acknowledge that this was an issue of international concern. To this day, there is still that lack of willingness to acknowledge it. And in fact, in our examination, and why the book was called COVID-19 in Asia, we found some of the best practice came from Asian countries. But I know there's a lot of discussion today, and there was in the first panel, about issues of human rights limitation on movement and travel restrictions. And I balanced that off with saying, you know, in this kind of a situation, human rights are going to be impacted, and we can't say they're not going to be. And there has to be a discussion of what the level is in impacting. So when the WHO issued their assessment of COVID response, and I often say this to my students, your homework is to read the assessment. It's easily available online. The paragraphs of recommendations are there. It is, I have to say, I'm not critical of the WHO's assessment of their response because they were critical of themselves. Director General of the WHO, Tedros, said that the lack of sharing of information, technology, and resources was a defining characteristic of the COVID-19 outbreak, and he called for an international pandemic treaty. The recommendations of the review committee, I quote one of them: countries that in 2005 approved the international health regulations in 2020 only applied the regulations in part, were not sufficiently aware of them, or deliberately ignored them. There were 40 recommendations directed at both the states and the WHO. The big thing was the timing. As I said in our chapter, we identified both delays on the part of the nation state where the pandemic first occurred, but critically, delays in the process of declaring the emergency. Responsibility for implementing the international health regulations should be elevated to the highest levels of government. Vast majority, and this was a real shock, the vast majority of countries had low or moderate levels of national preparedness. They also called it legal preparedness, that states must legislate and implement legislation to enable response to public health emergencies. And that was even true in my own country, Canada. I had been consulting with the government of British Columbia, for example, and there was a lack of vision on the part of public officials to think that this might happen. Oh, well, it's a once in a millennium kind of event, was the kind of the response. Well, I don't know if anybody's heard of monkeypox, but here we go again. So in many states, legislation was not fit for purpose. Notification: states should share information with the WHO as soon as it becomes available. And I know we're having a presentation on this panel about technology. And the report is full of the fact that there needs to be coordinated technological response. So risk assessment, a need for high quality risk assessment. To be fair to the members who were trying to decide whether this was an emergency of international concern, we're dealing with data that wasn't appropriate. The review committee again recommended consideration of a global treaty on pandemic preparedness and response. And this has now been accepted in the special meeting of the WHO Assembly in December. But my question is, will a treaty actually strengthen the global health architecture? There can be, and one of the reasons is international lawyers love to draft treaties and they're interested in treaties. But I've always been skeptical. I'm much more of a fan of customary international law. And I say that the international health regulations are part and parcel of the architecture of customary international law. And within the international health regulations, there can be review conferences, encouragements of preparedness and action, establish better warning systems, use transparency in WHO decision-making, and critically, of course, which is usual for international organizations, expand the funding base. My argument there is that already we have a problem, a weakness in international compliance, and that has been the case throughout my career, my 20-year career in international law. It's fine. Standard setting, however, is really important. And I've got to tell you, as late as 7 o'clock this morning, because it's morning this time, it's 8:30 now, I wasn't sure whether I was going to support a pandemic treaty or not. In balance, I think I do. The reason for that is I think standard setting in international law is very important. Now, I haven't seen a draft text. If anyone else on the panel has, I looked and couldn't see one. But I think if that treaty embodies notions of international and state responsibility, specific guidelines for how notification, a definition of what a pandemic is, that might provide important standard setting. But the age-old problem of ensuring international compliance remains. As with all disaster law issues, nations must prevent, prepare for, and respond to national health emergencies. They need to get their head around the fact that national health emergencies are disasters in the sense that they are, in some ways, definitely man-made disasters, but they constitute crises that the government needs to respond to on an emergency and top-level basis. But the WHO, too, must provide leadership and more timely responses to declarations of emergency. They must not respond simply to political pressure about when or if. They must look at the science. And that is why I relied so much on health articles, because the science was clear. The science indicated that this was a pandemic. And sadly, we're going to have a lot of presentations on travel restrictions. I have not yet arrived at a conclusion as to whether travel restrictions were necessary, were important, because quite frankly, by January 30th, it was too late. The pandemic was global, and travel restrictions at that point, it was too late. Although you might hear from some smaller countries that were able to prevent COVID spread, but even those countries like New Zealand, eventually COVID reached their shores. So as far as what kinds of health responses, I think we need a lot more discussion about what are the appropriate responses given our human rights obligations, our global human rights obligations. My final point is this. I despair when I look at the fact that the international community couldn't even get its act together to respond to vaccines that had been developed. These issues of copyright and not sharing technology, quite frankly, I think it's appalling. And if we don't understand, and it's basic science, if we don't combat COVID-19 everywhere, someone like me is going to get it. And the fact is that we did not have an international strategy to combat COVID-19, and we do not have so to this day. Thank you very much.
Thank you very much, Professor Breau, for your extremely insightful presentation. Our next paper about evolving understandings of the effectiveness of international border control measures during the COVID-19 pandemic will be presented by Dr. Karen Grépin, Associate Professor of Public Health in the Li Ka-shing Faculty of Medicine at the University of Hong Kong. Dr. Grépin, 20 minutes, please.
So thank you. I'm going to attempt to share my screen. There's always that tense moment when you never know if it's going to work as you intend. But shout out if you don't actually see my screen the way that I hope you do. So thank you so much for inviting me here today. It's actually quite a relief to be in a conference venue in which I'm one of the few public health people speaking about COVID-19, because I feel like that's been my entire life the last 2.5 years. I just also want to emphasize here that I am not an epidemiologist. I am a social scientist that exists within the School of Public Health. And so my perspectives on this might be slightly different if you had invited an epidemiologist. So since the beginning of the pandemic, really since as early as early February, a group of researchers and I, some based in British Columbia at Simon Fraser University and the University of Maryland and elsewhere, decided to start thinking about the role of travel restrictions. And so we've been working on this topic together. I hope, can you see my screen? You probably can't. I always have this problem. Let me just do this one more time.
Yes, we can see it.
We can see it, this is always, and does it change?
Yes, it does.
Okay, great. Okay, I'm in good shape. Okay, so we've been working on government response to infectious disease outbreaks for many years. Myself, I've been working on it since HIV, Ebola. And so this question about travel restrictions come up over and over again. And we knew that this was going to be an important issue in the context of COVID. And so we've been working on it since then. Travel restrictions are not a new thing. As long as people have traveled around the world, viruses have been there, and they've been very keen travelers to go along with their hosts in order to find new people to infect. In fact, this sort of tension, the fact that people coming from elsewhere can introduce public health threats, is really ultimately what led to the first forms of global cooperation around health, and it effectively led to the establishment of the World Health Organization. And the main legal framework, and others here are going to be much more experts on this, that oversees a lot of this global cooperation around infectious disease threats, is known as the International Health Regulations, the IHR. And the goal of this framework is really to prevent, protect against, and provide a public health response, a coordinated public health response to the international spread of disease. Just to be clear, all state parties agree to follow WHO's recommendations when it comes to trade and travel restrictions, following the declaration of a public health emergency of international concern, or a FAIC. And countries may still impose additional health measures if they so desire. However, they must be based on a series of conditions, some of which I won't go into. But critically, and this is why my work fits into this, is it has to be based on evidence. The WHO has consistently recommended against travel restrictions, almost to the point where at the beginning of this pandemic, there was almost this idea that one could not impose travel restrictions in the context of travel of an infectious disease outbreaks, meaning it was almost so ingrained into the idea of what the IHRs were supposed to do. And in fact, when the WHO declared, we didn't call it that at the time, but COVID, a public health emergency of international concern, it recommended against the adoption of any trade or travel restrictions. And it has consistently done this. It has softened its language a little bit on this topic over the course of the pandemic, but it's always been consistently against the use of the measures in the context of COVID. The reason for this, and you can see this directly in Tedros's tweet on February 1st, is that they need to make evidence-based decisions about what policy should be placed at the border. And so what evidence did actually exist at the time at which this fake declaration was made? The first point I want to make is we actually knew nothing about COVID, or we knew very little about COVID at the time. And all of the evidence that did exist around the effectiveness of travel measures came from other infectious diseases. So meaning SARS-CoV-1, pandemic influenza, MERS, or Ebola, for example. These are the studies that existed largely at that time. And those studies generally found that the evidence around the effectiveness of these measures was generally limited, meaning you could delay the importation of an outbreak, but only for a couple of weeks, not for a long time, and therefore were seen of limited value.
Sorry to interrupt you, sorry. I think the slides are not moving.
Yeah, that's what I was afraid of. Okay, I'm just going to stop share. And I'm going to try again.
Thank you very much.
Okay, thanks. I'm not a PowerPoint user, and Zoom is a little bit biased against us, and so it always comes up. Anyways, historically, however, what I would say too is the types of travel measures that were used look very different from the types of travel measures that were actually implemented during this pandemic. So where we saw a lot of action before was around, for example, providing travel advice, exit or entry screening, or some limited forms of targeted travel restrictions against travelers coming from particular places. But it was really citing this evidence that the WHO made its recommendation not to recommend any travel restrictions in the context of COVID. So what actually happened? So I'm sharing with you today some data that I actually haven't shared before. This is based on a forthcoming paper that I've been working on, which has been trying to build a database around the adoption of international travel restrictions by countries around the world. There are a number of databases out there, policy trackers, the Oxford one you're probably familiar with, CoronaNet. However, we found them very inadequate to study travel restrictions for a number of reasons, one of which they all group them into very weird categories. We didn't think were good representations of the types of measures. But also they didn't have good information on who was targeted, which countries were targeted. So we spent the last 6 months or so going through existing databases, collating them, and trying to create our own database of travel restrictions with better information. And there's basically 16,000 of these measures that have been adopted since the beginning of the pandemic by countries around the world. And what we've learned from this is something that's been cited, although I don't think it's ever been shown, because the data on this are held by the World Health Organization and not shared transparently. But all state parties eventually did impose some form of travel restriction. This happened by early April, so it was after the fake declaration. It was actually also after the declaration of a pandemic, the less legal but still important declaration. What we see is the types of measures did change over this time period. Early on, we did see those old kinds of measures being adopted, screening and so on at the borders, and eventually being replaced by other forms of travel restrictions that were not used as widely in previous outbreaks, such as the use of quarantine, full border closure, and as well as testing. We also have been looking at, for example, when these measures were adopted. And one thing that is important to note here is while a lot of measures were adopted early, so some measures were adopted even before the fake declaration, many at that point, but the real jump came at the declaration of the pandemic. But not just that, we actually see countries continuing to tweak and use measures over time throughout the pandemic. So I'm showing you data here through basically the first 16 months of the pandemic. But even into the fall of last year, we saw a number of countries imposing travel restrictions when the news of the Omicron variant was starting to spread. So what does this all mean? What have we learned about the evidence of the effectiveness of travel measures during the COVID-19? I'm just going to try to make some quick comments around three questions. One is, how can international border control measures reduce transmission? I think this is actually something that isn't quite widely appreciated, and I'm just going to share some thoughts on that. Were international border control measures actually effective in the context of this pandemic? And again, share some thoughts on that. And then briefly try to comment on the theme of this panel, how should we change the way in which evidence is treated either in the IHR or whatever pandemic treaty may come along. So the basic logic of a travel restriction is that there are two different places. I'm just going to, for the purposes of this, call them point A and point B. These could be two countries. These can be within a country. These can be almost anywhere. You can think of one scenario in which point A has a new infectious disease, point B doesn't have it. Or you can think of another scenario in which point A has perhaps more cases or a higher level of cases than point B. And so the primary goal of a travel restriction is to try to reduce the public health impact of travelers coming from point A to point B. And it can do that in a number of different ways. So there are actual different mechanisms by which this might happen. One is actually in reducing just the number of people going from point A to point B. This is what's widely known as the deterrence effect. It's actually one of the things that's least studied, but in my mind, probably actually had one of the biggest impact in terms of this pandemic at the point when many people just literally stopped traveling. You can also reduce the fact that you can reduce the probability that a traveler is infected. You can reduce the probability that an infected traveler will enter into the community, and you can reduce the probability that an infected person in the community can therefore transmit it into the community. And travel restrictions can have an impact on any of those things. As I mentioned, the types of travel restrictions adopted during the COVID-19 pandemic are very different from what we've seen in the past. And so this is based on some work with some of my co-authors in which we've been just trying to document the different types of measures. We need to do this in order to create our typology for our database. But you can see there's a wide range of them, everything from what we've seen before, but to new things that we've never seen before, requiring health insurance in order to go to a place, the use of rapid tests, and so on and so forth. These ceilings and quotas, which were mentioned previously in the Australia panel. But not only that, and so all of these measures can have some impact on that public health effect. Some of these measures are actually usually adopted early on before a traveler leaves their country. Some could actually be adopted at the level of the border itself. Then some actually happen in the country in which people arrive to. All of these measures can have an impact on any of those public health measures, largely because of the deterrence effect, right? All of this is really complicated. And all of this creates lots of hassle to the point where many people just stop traveling. And not only do travel restrictions have an impact on that, on the bottom, on the right there, I even talk about things that are not government policy that actually probably also have a big impact, and for example, on people's willingness to travel. Conferences were all canceled, all kinds of activities were canceled. All of those things actually greatly reduce the level of travel internationally or domestically, and those things probably helped as well. So there has been a number of studies that have looked at the evidence around the effectiveness of travel measures. And there's now even what I would call kind of 4 good reviews, I think broad reviews of some of this literature. 3 of them were written by a group based largely in Germany, although expanding its geographic reach, and commissioned by the World Health Organization, using Cochrane methodology to look at these issues systematically. And a paper that I wrote myself, also looking at the early evidence around the adoption of these measures in the early phase of the pandemic. I think generally there's some good consensus across all these studies about what worked, what didn't. One thing I would say is travel restrictions broadly, a lot of the types of measures that were actually implemented, in fact, I would also probably argue the bulk of the measures that were adopted during the pandemic had there's very limited evidence to support their use. That doesn't mean they weren't effective, but there's very little evidence of it, unless they were implemented early, in which case there generally is a lot of evidence to support the use of those measures in terms of having an impact on the pandemic outcomes. Universal measures tend to be more effective than targeted measures. And there is very good evidence around the role of quarantine, especially when it's coupled with testing, in having very large effects in terms of reducing transmission, right? So, I mean, this is not surprising to anyone who lives in places like Hong Kong or Australia. If you put these measures in place at your border, you can reduce the probability that cases make it into the community by very high levels, in fact, upwards of almost to 100%. At the same time, too, I'd say no measure is 100% effective. And in every case, there's been some exception, and usually sometimes it's just like the silly stuff that happens, but no measure has ever been 100% effective. The other piece of evidence, of course, are the countries that, which we might call today as the zero COVID places that were able to achieve local elimination for extended periods of time throughout the pandemic. What did they do? We know that most of them acted early. Not necessarily before cases arrived in their country. In fact, almost all of them had cases and had widespread community transmission before they put in place the types of measures that were eventually effective. But they were generally very universal. And so they put these measures in place early and were able to take advantage of them. Most of them started with other forms of quarantine, but eventually moved to managed or centralized quarantine. A lot of logistical reasons for this, but also effectiveness issues. Most imposed ceilings or quotas on the numbers of travelers. This is really important. Again, this idea that the amount of travelers is actually really important, but also practical reasons, right? If you're going to put everyone in a quarantine hotel, you have to put limits in terms of who can get in there. All of them experienced breaches of their borders. Every single place had cases eventually make it in. Only those that had strong domestic measures were able to get those back under control. And this is actually where we saw a lot of departure from the kind of former successful places in Southeast Asia to the ones that were eventually able to keep this in place for long periods of time. Interestingly, almost all of them have now moved away from zero COVID and strict international border control measures once they were able to achieve high rates of vaccination, and once the arrival of the Delta and Omicron variants, which actually made it very difficult for them to continue this with the exception of China. There are a lot of limits, I would say, also in terms of the quality of this evidence base. Almost all of the studies, even today, are modeled. There's actually very limited real-world evidence that have been integrated in a lot of these reviews. And I think that's also partially for a lack of creativity. I think there's a lot of evidence out there. We're just not looking for it correctly. There's limited evidence around whole categories of travel restrictions, for example, border closures and travel bans. In fact, most studies that look at this actually just sort of group them together and just sort of call it all reductions in travel. I think it's going to be incredibly difficult to eventually get a pure setting in which we can evaluate just the impact of travel restrictions. The reality is travel restrictions were always adopted alongside other types of measures being put in place, and usually in response to changing epidemiological conditions. And so it's going to be very difficult to get a pure example of this. And so we probably shouldn't spend a lot of time looking for them, but it doesn't mean that we can't without look at this knowing that there might be some limits to what we can find. Another important limitation, I think, is where we have learned a lot about travel restrictions come from places where we have good data. And places that have good data are usually the places that have really strong border control measures in place, such as the zero COVID places. And so you look at the studies that have actually been published, many of them, the real world examples, are actually in places like Hong Kong, New Zealand, and Australia, where of course we know those travel measures have been effective, but what does that mean from other places? There's limited evidence beyond the containment phase. Most of the studies still look at that initial question of like when there's point A has cases and point B doesn't. But of course, as I've mentioned, countries have kept these measures in place for two years now. It does suggest that there's at least a belief that those measures continue to play a role in other stages of the pandemic, and we don't know much about that. And there's limited evidence about the non-health benefits, or at least have been poorly integrated into these discussions. So what does that mean? Did travel restrictions work, and how should we think about integrating the role of evidence better into IHRs or whatever is going to come next? I personally think, I actually think travel restrictions, the ones have put in place in zero COVID, were extremely effective, and I'm very willing to say that. But I would say that most of the measures that were put in place globally probably had very little effect. And therefore, it's kind of one of these things like either you do it and you do it well. Beyond that, it doesn't make a lot of sense. And so I think at the same time, we've learned that travel restrictions can be extremely effective. and at the same time to be of limited value. And so it is the lesson that we've learned before, which is that they're limited evidence, but that's just because we didn't do them the way we did them this time. And if they are done in those ways, they can be effective. I'm not suggesting that they should be done, but I'm saying they can be effective. The second piece here is that every virus is different, or every infectious disease or every public health threat will be different. And so we actually don't need generalizable recommendations. What we need is frameworks or decision tools of ways of thinking about what might be different in different contexts. And knowing that evidence will probably not exist when we're dealing with something we've never seen before. And so, in fact, people are talking now about, monkeypox, all these types. We know monkeypox. It's been around for 60, 70 years. We, believe it or not, there are people who study this. We know a lot about it. It's probably not something that's going to become a pandemic, and therefore it's not something that we should respond to with travel restrictions. But there might even be a new variant of COVID that we may want to think about this again. So who knows? Another piece of this is, again, this idea of acting early makes a big difference. That is something that the evidence did show us. And therefore, and I think Susan's presentation was talking these delays, all of these delays. And if you're going to do these things, you do, contribute to poor outcomes. So if you're going to do these things, you really need to be thinking about doing them early. WHO recommended against travel restrictions. Had they not, we could envision a very different scenario, right? So compliance is important, but it's also important that they make the right recommendations. And so it's not clear that compliance in this particular area would have actually made things better. And it's possible that some of the travel restrictions that were put in place early actually were important. And then just briefly, as a researcher, data on this is not great. And we're never going to learn fully about the role of travel restrictions without making improvements in data. And that also means making the data that exists open, right? WHO has better data in terms of what countries are doing, and those data are just not available to the international community. And that's a real tragedy. So I thank you for your time, and I'll stop there.
Thank you very much, Karen, for your interesting presentation, which brought us with perspectives that a bit different from Professor Breau's. And I'm sure that in our questions and answer session, we will have a very nice discussion. I would turn the session over to my co-worker, Dr. Kelvin Ho, Associate Professor and Director of the Center for Medical Ethics and Law at the University of Hong Kong, to discuss digital capacity and the proposed International Pandemic Preparedness Treaty. Kelvin, 20 minutes.
Thanks so much, Eric. And of course, many congratulations again for receiving the Young Researcher Award.
Thank you.
Well, that said, it's been a note of thanks, of course, to colleagues Chris Zabia and also to Ms. Phoenix To for putting this together. Humbling experience, certainly, speaking after Susan and Karen. Let me just get my slides going, and then here we are. I do hope that it's coming across to everyone. Let me know if they don't get across. So a little bit different from Susan's focus. The presentation that I'm making will be a bit more forward-looking, speaking to this notion of digital capacity in response, in a way, to how a number of countries, particularly those across East Asia, have taken on the modalities in response to this particular pandemic. And then also, of course, in anticipation to current discussion, given that the World Health Assembly is meeting this very week in relation to, of course, the proposed International Pandemic Preparedness Theory. So, well, my message is really quite simple. This is essentially an overview of my key points. I'd like to introduce this notion of digital capability or capacity, depending on how you want to refer to this particular notion. And of course, I'd like to, in this presentation, focus on digital health in particular. And I mentioned this, as I noted earlier, in response to the various digital modalities taken on in various jurisdictions in response to this particular pandemic. I think there are good reasons to consider a need for a new treaty because for the reasons that were set out in the presentation, you'd see that what we have in the international health regulation is essentially focused on surveillance. It's not a regime that's been developed to manage a particularly long-drawn pandemic for a number of reasons that Karen has already mentioned in her presentation. And I thought it's timely to look into digital health in particular because in 2018, the World Health Assembly has already actively engaged in the possibility of building up or scaling up on digital capacities of countries around the globe. There is a rudimentary system that's been introduced under the international health regulations, as we shall see, so IHR in short. And that, again, is essentially focused on surveillance. There are, as we have heard, some limitations to that regime. I'm not sure to what extent such limitations could be addressed within the remit of the current IHR, but of course the IHR itself could be amended as we shall see in a bit. The last major change having occurred following the outbreak of SARS. Of course, IHR remains the key legal instrument that the WHO oversees, apart from, of course, the Framework Convention on Tobacco Control. I want to speak a bit more about how our experience with COVID is quite different from some of the earlier pandemics in the not too distant past. There wouldn't be time to go into some of the details, for example, our experiences with SARS or with Ebola or with Zika for that matter. But just focusing on COVID, you'd see that digitalization is a very prominent feature, particularly in terms of contact tracing and also in managing the outbreak with vaccination certification, as many of us in Hong Kong would be very familiar with. And I'd like to just speak very briefly about what I think, if we are to have this particular pandemic preparedness treaty, what might go into this particular framework. And I do think it's important to incorporate data ethics with focus on a number of global justice issues. And then just speaking to this particular legal determinant, thinking harder or more carefully about the use of personal information and the role of data in evidence generation. So with this, just to introduce this notion of data capability. So that's drawn from the capabilities approach. Some of you may already be familiar with this concept. So that was first introduced by Amartya Sen and then developed or advanced by a number of other scholars, including Martin Nussbaum. So you'd see that this particular notion has really been applied in a global health context for or in a number of concerns or contexts or situations, but not quite so much in connection with pandemic, and particularly not in the use of digital modalities in response to a pandemic or essentially as pandemic countermeasures. I think there are already some important work that's done in the human rights as well as internet rights literature that could be drawn upon to, well, essentially lend substance to this notion of digital capability. But in a very broad way, what I'm hoping to do, at least in introducing such a notion, is to introduce a conceptual framework. There wouldn't be enough time in this presentation to go into some of the details of this framework. But essentially what this framework will attempt to do is to assess individual health and well-being, evaluate social arrangements, as well as to inform the design of policies and proposals about social change, particularly when we are confronted with some of the exigencies within a pandemic situation. So that is the broad conceptual framework that digital capability speaks to, and I'm hoping that some elements of this will be taken up in the proposed international pandemic treaty. Because when we think about capability, again, that draws from Amartya Sen's earlier notion of it, is essentially the opportunity to do or to be what a person, or at least in a global context, a state has reason to value within a digital environment. So it will speak to particular human functioning. So even in the aggregate, this particular notion, I think, will have pertinence within such a framework. And of course, that could be contrasted with some of the other capabilities that we can think of. So I'll touch more about this, but if you should be interested, of course, happy to discuss that further during the Q&A session. So going back to the IHR, if you see its purpose and scope, of course, that's set out in the treaty itself. You'd find that nothing is said about digitalization. So of course, to be fair, it wouldn't have, or the sort of digital modalities would not have been envisaged at the time it was last revised in very substantial ways. Of course, that would be in 2004, leading to the 2005 version of the IHR. So that essentially just intended to underscore some of the changes that were not anticipated at that particular point in time. But if we were to look specifically into the framework, you'd see that as a legal framework, it is essentially directed at surveillance or a number of surveillance objectives and more immediate responses to such surveillance work being done. So that there will already be some form of certification in response to, for example, yellow fever. But again, that sort of certification would be in a more conventional sort of modality that's being taken on, not so much in thinking about the sort of digital tools that could today be applied. And of course, there will be a number of travel restrictions to which digitalization will, I would think, find rather ready application in a number of member states. But of course, what's important to highlight is that while we do see some WHO member states as having the digital capabilities to take on and to implement such technologies, but we find that a significant number of jurisdictions do not as yet have such capabilities, a point that was raised in the World Health Assembly discussion at 2018, and then, of course, as we see in today's context, made very manifest in the way that different jurisdictions have responded to COVID-19, and only a small handful of jurisdictions having made effective use of digital proximity tracking and contact tracing for that matter. So looking at Article 5 of IHR, I just want to highlight the point that it does provide for surveillance, but again, this is in relation to the detection of novel or outbreaks that may be of concern. And this particular article, as well as its notification provision in Article 11, has been successful in setting up a surveillance mechanism, a global surveillance mechanism that has by and large been effective. Granted that there have been a number of delays, but it's not so much, I would argue, from the surveillance mechanism that's been put forward. It's more of the decisional process or processes that you'd find within the organization of the WHO. So in terms of what these articles have by way of implication or implementation and the sort of setup you'd see. So the ESPA, for example, is a means by which you'd have WHO member states feeding information to WHO, and this information being applied in a number of ways. I think there are some important points that we could already gather from the information that's been supplied to the ESPA system. Well, what we see, of course, from the current outbreak and also in previous outbreaks would be, of course, the IHR essentially being the legal basis of this particular information or surveillance network many of you would already be familiar with, and that's the Global Influenza Surveillance and Response System. Of course, GISRS, in short, remains the most developed and advanced of WHO coordination system of laboratories. So as you'd see, as of earlier this year, it's into its 70th anniversary, that's right. So you'd see it's been around for some time and it has expanded. You'd see that it has been rather effective in terms of its surveillance purpose. As I've noted earlier, essentially the legal grounding for this setup is based on the IHR, and you'd find that its activities have been further supplemented by a number of other arrangements, particularly the Pandemic Influenza Preparedness Framework. Some of you may already be familiar with this, essentially speaking to the sharing of certain influenza pathogens as well as related information. So what we see here is that the IHR essentially facilitating the establishment of such a surveillance mechanism, which has rather effectively been implemented. So some of the challenges that we see, I would argue, does not relate to the technical features of this arrangement, but perhaps more in terms of the managerial management, governance, and perhaps political dimensions in relation to the declaration of the PHEIC. So where we think about health emergency preparedness, generally you would find that we're focused on, say, the component of legislation and financing. So just to think about legislation, for example, we do not have a harmonized landscape, as you see. So some member states of the WHO are will have more comprehensive pandemic response policies as well as legislation in place compared to others. And that is the same case for the National Health Emergency Framework that we find in different jurisdictions. And you see that this is important to note because the difference is even more stark when we think about the digital capabilities of different WHO member states. So just looking more broadly in terms of the digital divide, you'd see that least developed countries continue to lag greatly behind what you'd find to be the case in many of the other jurisdictions. And then, of course, with the advanced economies essentially leading in terms of digital capabilities. Now, if we want to think differently, I should say, about a pandemic, particularly one that's like COVID, one that is protracted, then we need to move beyond just having an arrangement for surveillance purposes, but to think about how to manage such a pandemic in a way that is consistent with legal as well as ethical. Looking at COVID-19, and here I want to think about it as essentially a pandemic that is relatively long drawn, or at least relative to a number of previous pandemics. So if you'd see in a number of key jurisdictions in Asia, so you'd find that in two of the largest economies, of course, we have got India and China, you'd find digital modalities being applied. So what's interesting in thinking about the differences between, say, the Indian approach as opposed to the Chinese one. So in India, there isn't a national pandemic response plan as such. So while the federal government took on the pandemic response plan initially, that's during the first wave of the pandemic, this counter-pandemic responsibility essentially was left to individual states during the second wave of the pandemic. So what's also interesting in seeing this change is that in terms of the Aryoga Setu, the digital proximity tracking or contact tracing app that was developed by the Indian government, it was initially actively deployed in response to the first wave of the pandemic, but not so much in the second wave. So, of course, there are a number of reasons for that, but I do think that this change is quite an important one to note. However, although digital proximity tracking was not actively applied during the second wave of the outbreak, we find that digital modality being applied for vaccination purposes. So that would be vaccine booking, for example, or vaccination booking, as well as certification of vaccination for a variety of purposes. So that you'd have a complementary app known as CoWIN being developed essentially to support the Aryuga Setu app that was developed for contact tracing. Of course, in China, the situation is rather different. As you'd see, there's been consistent application of digital modalities of various sorts. So quite similar to India, what you'd find is that you have got different apps in place. But of course, what's different is that whereas in India, you'd have the federal government essentially developing its own digital tool or digital app in the Aryuga Setu, we did not see that in China. Of course, you'd see that different provinces working with, well, essentially two main software companies, of course, developing an app or various apps, and then a degree of harmonization coming into place as the pandemic progressed. But what you see, of course, again, quite similar to India, is that while these various digital modalities continue to be applied for contact tracing purposes, they have also taken on certification functions. And if we are to scale up in thinking about certification in a national context to something of an international kind of platform for a variety of purposes, including supporting international travel, of course, you'd find that there are a number of concerns and also a number of technical requirements. So WHO has, in the second half of last year, issued a guidance document, quite interestingly, this particular initiative supported by the Gates Foundation. So you'd find this particular document speaking to particular digital capabilities that need to be in place within a system. Of course, one can query how many of the member states actually do have such technical capabilities. But of course, in relation to this particular document, the concern was in relation to two scenarios in particular, and that would be the continuity of care and also the proof of vaccination. But what I thought has been very important and helpful in terms of the discussions in this document would be the minimum requirements that WHO member states should have. And this would not be just the technical requirements, but also some of the normative features or the normative conditions that need to be in place. I use normative broadly to speak to the ethical kind of or governance related kind of arrangements, as well as legal arrangements that need to be in place. In terms of the ethics, the document did not speak too much about the law, but in terms of the ethics, you'd see that it's quite consistent with a number of documents that WHO has already issued, highlighting, of course, the need for equity, the need for respect, and of course, the need to monitor for effectiveness and inclusivity. So some of these concerns one can appreciate the importance, especially with very important implications on public trust. So these points were underscored in the document, along with a number of values as well as recommendations. So as I've noted, you'd see inclusivity in decision-making as one of them, and of course, transparency, accountability, responsiveness. But you see that ultimately, if we think about how all of these values are to be animated or how these recommendations could be given effect, some sort of framework will need to be in place. And this framework could speak generally to how a pandemic itself should be responded to and should be managed beyond the initial phase. But it also speaks to the deployment of particular capabilities, or it should speak to particular capabilities, including digital ones. So I thought that when we are to think about the proposed pandemic preparedness treaty, we should also be thinking about the sort of conditions or the sort of determinants that need to be in place in order to support the data infrastructure that will help us to not only detect surveillance, which we in a sense, already have a particular mechanism that works relatively well in place, but also moving beyond that in managing the pandemic as it progresses, and also in exiting from that particular pandemic. As you'd see, and also noting what Susan has mentioned earlier on, even when we think about exiting from this particular pandemic, if exit is the right word, it's rather haphazard with different jurisdictions doing their own thing, essentially. So a particularly helpful point to note in the document would also be the data protection principles. Of course, when we think about digital modalities, they speak to the collection, management, use, and essentially the erasure of what might be personal data, or for that matter, de-identified information of various forms. So the data protection principles are, as you might not find too surprising, relatively simple, similar to what would find in the GDPR of the European Union, but again, also not that different from what we'd see in terms of data protection principles of the Personal Data Privacy Ordinance in Hong Kong. So I thought that if we are to have an international pandemic preparedness treaty, and if this document is to speak to digital capabilities at large, then I think one very important feature to think about will be the data protection landscape that we see around the world. There is as yet no uniformity in thinking about how personal information ought to be handled. IHR has got some very, again, rudimentary provisions on the management of personal information, but essentially Article 45 speaks to the involvement of WHO in the use of personal information, but not so much in terms of how such information could be used to support a number of digital modalities or to support the building up of or the deployment of digital capabilities as a pandemic countermeasure more broadly. So even if we were to move away from the IHR and if we were to look at the data protection landscape around the world, we'd see that it's far from harmonized. So there is no consensus in terms of the sort of protection, minimum protection that ought to be in place, even in the context of a pandemic where, of course, you'd have a lot of collective concerns, as well as where collective action is drastically needed. So for example, although you'd see various jurisdictions here highlighted in red, so is according to DLA Piper, these are the jurisdictions with relatively robust data protection laws. But as you note, whereas in the US, there would be some general provision, not so much at the federal level, in fact, quite limited. So if we were to take into account state-based protection of personal data, and to contrast that with what you'd find in the European Union, you'd already see from the collapse of the privacy shield between the US and the EU that there is as yet no agreement as to an appropriate norm that should apply to personal data or the exchange of personal data, whether and this would be during peacetime, and one would argue perhaps even more difficult in a pandemic kind of situation. So in conclusion, I thought that if we are to agree that there ought to be a better support on how we ought to prepare ourselves for the next pandemic, how we ought to work together, then digital capability ought to be part of the conversation. As we have already seen the value or the importance that has been attributed to various forms of digital modality, particularly in a number of jurisdictions. I think if we are to go back to the World Health Assembly Digital Health Resolution of 2018, as well as a number of WHO recommendations that followed, I think these are some of the areas that the Pandemic Preparedness Treaty could speak to, because they will be of pertinence to managing a pandemic, and of course, in determining how an exit ought to look like. And what really should be front and center of such a pandemic treaty, I would think, are concerns of global justice. So as Susan has already noted, we see a lack of coordination in response to this particular pandemic. we have got difficulties working across different stakeholders, particularly when we think about public and private sort of organizations in response to this particular pandemic. So I think that's where we should get started in thinking about preparing for the next pandemic. So with this, I see Eric appearing. I guess my time is up. So thank you so much for your attention. I very much welcome your thoughts and comments.
Thank you very much, Calvin, for sharing with us your discoveries on this important topic. The floor is now open for questions, general comments, and reflections on the presentations can also be typed in the chat box for everyone to see. Perhaps I can start off with the first question for Susan. Could you elaborate a little bit further on your interesting point that the international health regulations have actually become part of customary international law? Thanks.
Yes, in our chapter, that was the first thing we looked at, because my question was this law? Were these binding legal obligations? And the international health regulations are part and parcel of the Constitution of the World Health Organization. That is a treaty that has been enacted by 196 states. So we're talking about universal enactment. And these regulations were adopted under that treaty. And there isn't any great persistent objector kind of situation, which you often get in humanitarian and human rights law. There was a general acceptance of the World Health, international health regulations. So my argument is that on any basis of majoritarian or everyone has to exceed the traditional controversies under customary international law, they seem to be met here. One doesn't have to get into a theoretical conversation about objectors versus non-objectors. Now, as with any treaty, you could also come back at me and say, well, Susan, I mean, the violations here were legion. But unfortunately, that's the way international law works. It's a treaty, it's standard setting. It has very little by way of implementation or what we call enforcement. But in terms of the standards, I believe they're customary international law.
Thank you.
I see Calvin nodding, so I feel better.
All right, so questions, comments are welcome.
I'll throw my hat in the ring. Susan, you mentioned very briefly during your presentation, the phenomenon of that you discuss a little bit more at length in your chapter. Certain Asian states sort of defied the advice of the WHO not to implement travel restrictions early on. But they did so on the basis you mentioned in the write-up of capacity building that was sort of done on the part of the WHO. So I'm interested in the question of, do you think this is a model that what these states did should actually be considered to be something that the WHO should recommend in the future?
Absolutely. And I'd be interested in Karen's view about this as well, because I was really fascinated by her paper, because the issue was that almost instantly, Chris, states had to go it alone. They knew because there was no consensus on even whether there was a pandemic. And some of the planning that had been done in Asia as a result of the SARS pandemic. This was prior to COVID-19. So there'd already been groundwork regionally. And that is why our book on COVID-19 in Asia was important, because we looked at best practice. But my point about travel restrictions, which I think Karen agrees about, is that unless it was done almost instantly, they weren't effective. And even in Asia, unfortunately, that came to be the case. So it was the issue of speed. And Calvin mentioned, these sort of political factors, the not wanting to scare the world kind of argument that was going on. But, nation states got to the point where they said, well, we've got to do something. We have to respond to this. I'd be interested in the other panel's views on this, though, because this is where I struggle.
So maybe I can invite Karen to respond to that a little bit.
Yeah, I mean, I think I agree mostly in that earlier is better. I also disagree that unless it was done instantaneously, it didn't have an effect. I mean, in fact, there was a lot of learning. We didn't have a real sense of what kind of travel measures were going to be the most effective, which ones were needed. Again, that evidence base just simply did not exist. And so we actually see a lot of adaptation and largely sort of increasing of intensification of the measures in places that eventually went on to have successful border regimes. And so, you know, and many of them complained that they weren't getting good advice from the WHO at this time, right? And in fact, in the whole time, WHO is saying no travel restrictions are bad. And so, you know, I think that timing is important. You know, I do think we have learned a lot. I think we'll be in a different situation going forward, but I'm also quite concerned that we haven't changed the mechanisms by which this process happens so that, you know, monkeypox should not trigger a shutdown of trade and travel, right? You know, what constitutes such a threat? And so I worry that we don't have the mechanisms in place to do that in a sufficiently fast enough manner that we will be able to really internalize the lessons from COVID.
And so I guess that opens the question also to just move back to Susan really briefly. I mean, you mentioned kind of a potential revision to the reporting requirement in your chapter as well. I'm wondering if you would support maybe a broader revision that emphasizes the need for an early intervention, given some sufficient level of evidence for that.
Well, that's exactly what this pandemic treaty, I think, from reading the literature, as I said, I haven't had a draft, is going to do, is saying there's sort of escalating urgency. You know, first notice that there's a problem, second notice, intermediate action. And this was what was so frustrating, because you go directly from 0 to DEFCON 4. You know, this is why the emergency committee had such problem, because they had to declare something. But Calvin, I'd be interested, because one of the issues that you focused on in terms of your digital presentation was this lack of transparency. You're trying to guess from media reports what's actually happening here. And again, the WHO still, as Karen said, is not releasing its data. And it seems to me that's so important to have appropriate data to actually be able to make these determinations. As Karen said, and you've got a health background, well, monkeypox isn't that kind of a disease. Well, I didn't know that. You know, it's like, so it's that kind of data that needs to get out there.
Yeah, thanks so much, Susan. This opportunity to weigh in on the discussion. So as far as the provisions of the IHR are concerned, you see that essentially WHO has got this rather difficult task of deciding when to impose, and for that matter, what sort of travel restrictions ought to be imposed. And that's really difficult when you have a novel situation or novel pathogen in place, you see. So there have been instances where WHO has been criticized for acting too soon, but then there were also instances where it's been criticized for acting too slowly. Of course, COVID might be one of them. Ebola was certainly another situation. So when exactly is right? Because I don't think this particular judgment is a matter of a purely technical kind of assessment. So there would be the political dimensions, but unfortunately, as far as the politics is concerned, I think it's very difficult to get consensus as to what is appropriate. And that, in a sense, speak to some of the data flow concerns, because when we do have information being shared by member states with WHO, you see in the IHR that these such information ought to be treated as confidential information, precisely because there is concern that other countries may just overreact. Look at what happened to South Africa when it indicated that it has detected Omicron, right? So rather than being supported, it felt itself being discriminated against and ostracized by the rest of the world. That certainly should not be happening, and that cannot be ethical. So, so obviously there are these sort of concerns, and when a public health emergency of international concern is declared, of course, that is where you should have freer flow of information. The confidentiality obligations under the IHR would no longer be as stringent. But then, of course, when we get to that particular point, there are other difficulties in terms of how governments respond to that sort of information. I mean, to be fair to WHO, as you see, when the information was out, when the PHEIC was declared, there was all kinds of misinformation, disinformation that was going on. You've got leaders giving all kinds of other signals to say that it's really not a matter of concern. So I'm not sure that these are the sort of issues that WHO has got any kind of normative power to address. So whether that's whether a new treaty is going to help that sort of situation, I don't quite know. But what COVID has shown us are some very important concerns on this front, particularly, as you say, Susan, in relation to how information is being shared and used by leaders around the world. Yeah, thanks again.
Thanks, Kelvin, for your insightful answers. Are there any questions from the floor?
I'll ask one more while we're waiting. I wanted to throw out a question for everyone about potentially looking at regional norms, looking at potentially different patterns of agreement that are maybe not global, but could maybe induce levels of cooperation a little bit broader than the individual state, given that there are potentially divisions over how to achieve this kind of cooperation. So I mean, we talked about in relation to Susan's presentation, Asian states that defied WHO advice. So there's a potential group there. Karen got into the zero COVID countries, but of course there are other divisions regionally or otherwise between states in terms of which mix of border control tools or technologies they engage with. And in terms of what Calvin is looking at, right, there's going to be different forms of agreement about data sharing, privacy, whether or not contact tracing is implemented, that kind of thing. So my question would be, is there a case for at least to kind of broaden coordination to look at either regional treaties or different levels of opting in for the sake of cooperation, whether it has to do with border control specifically or other forms of pandemic disease control.
I'll start with that one. I think, this question, especially around travel restrictions and so on, I think this idea is true that, something were to emerge anywhere in the world, it could potentially spread anywhere almost instantaneously. So in that sense, I think, in particular when it comes to things like travel restrictions, I think it is really important that there is a regional, a global norm for these types of things. I think what we actually saw with regards to travel restrictions were regional patterns evolving, not so much because that's where it should be, but because that's where they could get agreements. So much about travel restrictions and everything else is this idea that you trust the other country to be doing the right things so that if you were to open up to them, that they would not hurt you, you won't be suffering the consequences from that externality. And I think the fact that we saw kind of regional attempts, within the European Union, the Asia, within Australia, New Zealand, and so on, is that they were able to get trust and agreement. I'm not saying that's how it should be done. I just think that's the reason we saw at that level, just because there was such a complete failure at the global level to coordinate around travel restrictions. And so, unfortunately, we ended up having to deal with it regionally when ultimately it should have been dealt with at a global level.
Thanks so much for the question, Chris. So let me just speak to that point as well. My sense is that it's going to be very difficult to get any kind of effective response, global response, unless the capability issue is addressed. I think it still goes back to what each WHO member state is able to do. So unless you have some kind of baseline capability that each member state is able to take on in response to a particular pandemic, you are going to see these differences. You're not going to get that level of trust. With limited information and with many member states understandably taking a very precautionary kind of approach in response to the pandemic, I don't think we can be too optimistic that there's going to be sensible, coordinated action in the foreseeable future. So quite pessimistic, I'm afraid. Well, that's my sense of it. I'm not sure if Susan agrees.
Well, I would have, Calvin, but then Ukraine happened. And I think there has been, at least from my European, North American perspective, a complete shift in understanding the need for global cooperation. I've never seen such unity in Europe. Now that could spill over. See, what we had was a particular point, a perfect storm. I mean, we had Donald Trump talking about bleach and not recognizing that the pandemic. So in terms of North American cooperation, it was non-existent. We had Boris Johnson in the UK not taking the pandemic seriously. So European cooperation. But there is a recognition now with the international armed conflict in Russia, Ukraine. I think there was a recognition that they got it completely wrong in COVID. I'm not saying that there's this conscious, we did this badly in COVID, we're going to do it right now. But certainly there is a resurgence of discussion of the need for a global community in response to catastrophe. That resurgence is hopeful. A different American president, a very chastened UK prime minister who damn near lost his job over this. There is a different sense. So in terms of your original question, Chris, on regional cooperation, I've done a lot of work on this in terms of international law. And I do think, I'm getting a bit theoretical here, that we need to discuss how we implement international legal order regionally as well as internationally. Yes, I agree with Karen, there needs to be a global response, but that also has to trickle down into our regional organizations because they've become so important in the international architecture. That relationship between EU. Look at this resurgent debate about NATO, for God's sakes, which I thought had been relegated to the ash heap of history. But regional organizations, non-international organizations are critical when you're talking about cascading down global order and global responsibility. Some interesting theoretical research needs to go on there, but I do think it's important.
Well, I think if time permits, let me just quickly speak to that point. So, Susan, I remain rather pessimistic because I'm not sure what the global vision is. And the problem is that you've got all these sectorial interests with essentially their own vested interests, with their own opportunity for political gain, you see. But with these sort of challenges, I think collective action is going to be difficult. Well, COVID is a huge concern, but COVID, I think, will pass. The next big challenge, I would say, will be climate change. And I'm not optimistic that we can get our act together in reducing carbon emission. That's not going to happen, I think. So that is the unfortunate reality of the world we find ourselves.
I concede to you on the point on climate change. I think we stunned our audience into silence.
Yes, indeed. But I really like our discussion a lot. If there are no more further questions and comments, then this brings us to the end of today's panel. Don't forget to drop by our next panel on interdisciplinary perspectives on pandemics and border control from 4 to 5 p.m., 5:30 p.m. Hong Kong time tomorrow. So thank you very much, Professor Breau, Dr. Grépin, and Dr. Ho for today's brilliant presentations, and see you tomorrow.
Thank you so much for participating. I deeply appreciate it.
Thank you.
Thanks so much, everyone. Thank you.
Thank you.
Take care.